everything. I'll remember this. Yeah. So in next 7-8 minutes we'll start.
Yes, sir. So Sandra, has your all your equipment moved? I remember your MEG was to move to another building. When I came,
Yes,
you
and
said,
we managed that. Yes, yes, yes. Yeah,
and it's
it was a
working
long process. It took almost 1 year.
to move the whole
Yeah.
equipment.
Yeah, because they wanted to save money, so we said that they should build a new shield, and then we should transfer only the equipment. But then they said no, this is too expensive. So we had to demolish the old shield, move the old shield, and then move the equipment. So it took time, but now it works well. So it's
So
okay.
the shield, when it was demolished, it was as in toto, like there was no damage or anything to it.
Well, we were afraid, and they said there is a risk, but then they managed to do it well.
Okay.
Yeah.
And the
But
other
we do
equipment.
more and more high density EEG, and only in patients, because we finished the research studies. We do the MEG only for clinical cases and only when the high density EEG is not informative. And that basically dropped the number of MEGs to 1/3 that what we did before.
Okay. Own HRU, the one which helps you condense the helium back again?
Yes, we can recycle the helium, and then our friends in Sweden got recently. It's experimental yet, but it's a full scalp coverage on scalp MEG. This optically pumped MEG. So this is still experimental, but I think that's the future.
Yeah. Yeah. So the high density EEG, which systems are you using?
Yeah, we EGI. Well, the same that you have.
Yeah, we have EGI too. Yeah.
Yeah.
So we do high density only for very complex patients, where we are not able to clear them straight away. So anything which is not cleared in the first epilepsy meeting which we have on the patient, we send it both for the EGI as well as MEG.
Yeah, that's what we used to do many years ago, but then we realized that we would save resources if we start with high density EEG. It's also less resource demanding, and then if that's uninformative, then we send to MEG.
So I think we still have 5 minutes more.
Yes.
So you have 2 talks. Do you want to modify the title of any of them, or
No, it's fine. It's fine. Yes.
Because I thought
I can't remember what my next talk is, but I remember that I agreed on the title, so it's okay.
Yeah, so it was the IFCN terminology, which
yeah, very
yeah,
sure,
because
no problem.
that is something which is your first hand.
Yes.
So you would be the best person in the world to deal with it.
I love spikes. Yeah.
So we have 123 who have joined in. They keep joining in. So I think we can
Sure.
start in a minute. Sir?
Sure.
Welcome all to the next in series of the Indian Epilepsy Society EEG workshop. As the Secretary of the Indian Epilepsy Society, I request you all to look at these classes on your laptop so that you're able to see the EEG epochs well. I also urge all of you who are not members of the society to become members so that we can pass on messages about classes to you all by WhatsApp and emails. I will now request Professor Manmohan Mendirata, who is the Secretary of the Indian Epilepsy Society and a very, very renowned epileptologist, to introduce our today's speaker.
Thank you so much, Dr. Manjari. Very good evening and good afternoon for our friend from Denmark. And Dr. Sandor is so well known world over. I will introduce the rest of the things later. He is always available globally on LinkedIn and Twitter, and he's a global teacher. He keeps on teaching people, and even I keep on reading whenever he puts it on LinkedIn or in Twitter, and I read very carefully. Very informative subjects he enters. Even the PhD students who are being appearing in the exam, he mentions about that. Encourage his colleagues to do well, and that's the quality of Dr. Sandor. We have known each other. We had been in the ILA for long, and Dr. Sandor is very active in ILA as well. He had been in a number of task forces, and teaching modules have been made with the kind help from him. Now, he is attached to Ars University, which is a corresponding university. He is the chairman, Danish Epilepsy Center of Department of Clinical Neurophysiology. But I thought that will not be sufficient. So I had to dig up from the internet something so that I can introduce. He has a large number of publications. And on one platform, that is ResearchGate, it shows 297 publication, 6,226 citations, out of which more than 5,000 citations are in 21-22. 21-22, so many citations. He has published very high impact articles, and he has, in addition to the citation, the reads are more than 55,000. So that speaks of the volume of a person. Not only that, he's deeply involved into epilepsy, care, teaching, education, publication. And he's currently the editor-in-chief of Epileptic Disorder Journal. So, lot to learn from him, and we all will be benefited today. We started this session on 4th January, and today is 22nd February. Every Wednesday we have talks. So today, Dr. Sandor, Professor Sandor, will be delivering 2 talks. And very happy to inform that usually attendance is around 350, Dr. Sandor, in our session, 350. Not only from India, but also from neighboring countries, that is SAARC countries like Nepal, Sri Lanka, Pakistan, Bangladesh, Indonesia, Malaysia, but also far away from Africa. Already 2-3 colleagues, Neera and others, have joined from Africa. You will see in the list. So, and it further adds value with your presence to this teaching program. We are very grateful to you. Please start with pattern of EEG patterns in status epilepticus in ICU. Thank you so much for kindly agreeing to spare time and teach the residents, junior faculty, and person like me. Thank you so much.
Thank you so much for this nice introduction, and thank you also for the invitation. It's an honor and a privilege giving this talk, and congratulations for this fantastic online event. And it's a really an impressively high number of participants you gathered. So without further ado, let me tell you about the outline, what I'm going to talk about today. So I'm going to talk about the indications for EEG in patients with altered consciousness or a suspicion of non-convulsive status epilepticus. I'm going to talk about the use of continuous EEG versus repeated routine EEG to detect these conditions. And in the end, I will focus about the EEG criteria for seizures and status epilepticus, because much of EEG is about pattern recognition, and this is what we are going to exercise today. So these are the indications, and you can see I put some items in this green box, and then I will put some items in the yellow box. And the items in the green box are not controversial. So everyone would agree that an indication for doing EEG is a suspicion of non-convulsive status epilepticus. Why? Because EEG is needed to confirm the diagnosis of non-convulsive status epilepticus. You cannot diagnose this condition without EEG. And when do you suspect non-convulsive status epilepticus? Well, these clinical red flags are really helpful. So for example, in a patient with known epilepsy, if he or she develops rapidly an altered consciousness, then you suspect that this could be because of a status epilepticus. The other very important thing, which is unfortunately quite often neglected in clinical practice, is a long post-ictal phase after a convulsive seizure. So if the patient is still in a post-ictal phase half an hour after a seizure, then you start suspecting that, well, actually it continued with a non-convulsive seizure. And then the presence of these subtle seizures, these subtle phenomena, which we will discuss in detail later on, these are some phenomena which may or may not be of epileptic nature. So basically what you need to remember is that a high index of suspicion for non-convulsive status epilepticus is needed, and a low threshold to obtain EEG is recommended. So I think this is the main take-home message of this slide. So have a high index of suspicion and a low threshold to refer to an EEG. So the other uncontroversial item is when the other clinical and paraclinical data do not explain the altered consciousness. So you have a patient with unclear cause or etiology of the altered consciousness. You tried everything, but you still don't have an answer. So in these cases, EEG is needed for differential diagnosis, because you need to differentiate non-convulsive status epilepticus from acute encephalopathy, from psychiatric conditions in patients with rapid and unexpected emergence of altered mental status in the absence of other plausible explanation. Why? Because in patients with altered consciousness but no clinical signs of seizures, still EEG has detected non-convulsive status epilepticus in 8% of the patients in the intensive care unit, and more than 1/3 of the patients in the emergency room. So even if you don't have the subtle motor clinical phenomena, which could be a red flag, even in those cases, it's worthwhile doing the EEG. Now we came to the more controversial indications. For example, other clinical and paraclinical data explain the altered mental status, but it's assumed that the non-convulsive status epilepticus worsens it. So practically this is valid for all patients in the intensive care unit. And then EEG is very useful for monitoring therapeutic effect. For example, if you want to titrate the sedatives by looking at the burst suppression, then you can do that, but it's controversial whether that's useful or not. So among critically ill patients in the intensive care units, almost 30% of the monitored patients with EEG had non-convulsive status epilepticus, so this strongly argues for using it. And non-convulsive status epilepticus, note that, is the admission diagnosis for only a small subset of patients in the ICU. Most patients develop the non-convulsive status epilepticus after the acute critical illness. So that's why, again, you need to have a high index of suspicion. Okay, so the next big question is to do continuous EEG versus several repeated routine EEG studies. And this is important, especially in those countries which are not so rich in resources as the United States. Well, we know from studies that doing continuous EEG improves the seizure detection, but it's also resource consuming. And it's uncertain whether it improves the outcome. So we know from the CERTA study, the only prospective multi-center randomized trial, which randomized patients with altered consciousness without recent seizures or status epilepticus. They randomized it 1-to-1 to receiving continuous EEG for 30 to 48 hours versus 2 routine EEGs of 20 minutes each. Of course, the continuous EEG increased the seizure detection, and also it led to a higher percentage of cases with modification of the anti-seizure medication treatment. However, there was no difference in outcome at 6 months. So if you ask the question, okay, I identified the status epilepticus more on the intensive care unit by doing continuous EEG, but does it help the patient? Well, the CERTA study could not prove this. And then, of course, we have lots of data from retrospective studies, yet I must say that even in the retrospective studies, this remains still controversial. So there are studies which argue for, but there are also retrospective studies which argue actually against it. So this is still controversial. Okay. So now let's talk about the EEG criteria for seizures and status epilepticus in critically ill patients. Now, you know, I'm a simple guy and I like simple thinking, so I will put all these criteria into this one box, and it's very, very simple. So ictal EEG patterns in the intensive care unit are the ones you already know from patients with epileptic seizures. So you don't need to complicate it. This is not rocket science. You are already familiar with the seizure patterns from the epilepsy monitoring unit, from long-term monitoring. Now, you have to look for equivalents, but in the intensive care unit. Now, back in 2013, a group of experts suggested this set of criteria, which later on became known as the Salzburg criteria for non-convulsive status epilepticus. Now, let me guide you through. So let me show you the flowchart of the Salzburg criteria. But very importantly, you see the entry into this flowchart. So the very first step is a clinical suspicion of non-convulsive status epilepticus. So the Salzburg criteria are not meant to be used as screening method on everyone, but you need a clinical suspicion of non-convulsive status epilepticus. And here we also have the time limits for the clinical phenomena, which were set in the paper by Eugen Trinka in the ILA paper on status epilepticus. So here we need at least 10 minutes of clinical symptoms to enter this flowchart. Okay, so you have that. So patients with at least 10 minutes of symptoms, which could be non-convulsive status epilepticus, then you do an EEG. And then if you see in the EEG epileptiform discharges, and these are in bursts and the frequency is over 2.5 hertz, over 2.5 cycles per second, then you can diagnose non-convulsive status epilepticus. We call this as our primary criterion in the Salzburg criteria. Now, we were a little bit surprised how people applied this in the practice. So people measured the wavelengths of individual cycles and took the reciprocal as the frequency. This can be misleading because although we say this is a rhythmic activity, the truth is that it's quasi-rhythmic. So if you measure it in the wrong place, then you can be misled. Also the same if you just calculate the frequency from 1 second. So to accommodate this jitter induced by the quasi-rhythmic nature of the frequency, it's best to take 10 seconds epoch and then count the number of the cycles you find in these 10 seconds. And that gives you a more reliable figure on the frequency. So here, for example, you can see very nicely, it's more than 3 hertz, more than 30 cycles per second during 10 seconds. So this is bilateral synchronous spike waves. So this corresponds very nicely to an absence status, which is also a non-convulsive status epilepticus. Now, this is the corresponding pattern you can see in the intensive care unit. So you see this spiky generalized periodic discharges which are rhythmical, and their frequency is beyond 2.5 hertz. And this satisfies the first or primary criterion of the Salzburg criteria for non-convulsive status epilepticus. So again, spike and waves with a frequency higher than epileptiform discharges with a frequency higher than 2.5 hertz. Now here you can see the same, but now you have it in focal. So the previous slide showed you a generalized pattern, and now here you have the focal pattern of spike waves. Here you can see mainly in P4, but also in the midline. This is an common average montage. And then I can show you the same here. I hope you can see my cursor moving on the screen. So here you can see the same in a longitudinal bipolar montage here. But again, focal, but still spike waves with a frequency beyond 2.5 hertz. Okay, now the other very, very important part in the Salzburg criteria is this evolving pattern. So here you can see a very nice evolution in time and space of the epileptiform activity. So you can see here where my cursor is moving that it starts in the channels in the red. So, you know, in our country, in Denmark, the political parties have the same color code. Our left-wing party, so the communists, usually get a red color in the parliament, and that's why we give the left-sided electrodes also the red color. And then the conservatives in our country, they use the blue color, and that's why our electrodes on the right side come also in blue color. So here you can see where my cursor is moving. Here you see a low voltage, high frequency activity. Now follow this with my cursor, so you would see a gradual change in time. Both of the morphology, the amplitude and the frequency changes gradually in time. So this is the evolution in time. And then the evolution in space is the propagation. So here at the beginning, you can see it only on the left side, and then it propagates to the right side. It involves very much the right side. So the propagation, that's the dynamic in space. So this spatial and temporal dynamics gives you the evolution, which is the other very, very important characteristic of a seizure pattern. So this is good for these cases where the frequency is under 2.5 hertz and you don't see an epileptiform discharge, but you see a rhythmic activity, because then you would need the secondary criteria. And here you've seen the first secondary criteria, which is this typical spatiotemporal evolution. And then I can show you several other examples. So here again, now I compress the EEG very much. So now between two gray lines, you have 10 seconds. And I also advise you, that's a very useful trick in your clinical practice. So if you want to assess evolution or fluctuation, compress your EEG. So look at 30 or 40 seconds on your screen, because you would see the dynamics much better, the evolution in time and space. So again, I compress this EEG very much, and then you can see this very, very lovely evolution in time. I hope you can see my cursor moving, but follow my cursor. So you can see that the morphology, the frequency, the amplitude changes gradually in time. So that is the evolution in time. And then the propagation, as I'm showing with the cursor, the propagation again starting in the red and then evolving the right-sided electrode. So it propagates from left to the right. And this is the dynamics in space. So you have a very nicely evolving pattern, and here you can see the same, but this time in longitudinal bipolar montage. But again, follow my cursor. So here you can see the evolution in time, and then the propagation, that is the evolution in space. Another example for the same, now it's less compressed, so now it's 1 second between the two vertical gray lines, but here you can see very nicely in a common average montage this very nice ictal pattern evolving especially in the posterior temporal right electrodes. And here is the same in the longitudinal bipolar montage. I hope you can see my cursor moving. So here is the very nice pattern evolving in time. Okay, then another secondary criteria is when you see subtle clinical ictal phenomena during these EEG patterns. Now let me show you what these can be. So let me play the video. So in the first patient, so focus on the perioral movement. So can you see there are these discrete movements around the mouth? I hope you can see it. So tiny discrete jerks. And then here you can see tiny jerks in the left thumb there. So then you could say, okay, but these are clinical phenomena. Why do we need EEG in case of this subtle but visible clinical phenomena? Why can't we diagnose just based on the semiology? Well, the problem is that patients in the intensive care unit can show this subtle phenomena also for other reasons. It can be the medication that they receive in the ICU. It can be the etiology. For example, if the etiology is a lesion in the brainstem, then they can have these kind of subtle movements without having status epilepticus. So we tried in a study to look at the details. We hope that some details in the semiology would help us to discriminate those that came on ground of epilepsy and those that did not have epilepsy. And we looked in detail on the body part, in which body part these subtle phenomena occur, how they occur, how they are distributed in time. But regardless how many features, semiology features we extracted, we could not make a distinction between those coming because of status epilepticus and those which did not have status epilepticus. So even in these cases, you need to do an EEG to confirm that these subtle phenomena are due to an epileptic activity in the brain. Now, let me show you another example. So here you can see these polyspikes. Well, if you have time-locked discharges, time-locked clinical phenomena, then you can say that this is a seizure. And if this is continuing, then it's a status epilepticus. So let me play this for you. So here's the cursor moving, and now we are approaching the polyspike, and then there is the myoclonus. And then again, the next polyspike, the next myoclonus. So this shows you the secondary criteria, which is subtle ictal phenomena during the EEG abnormalities. Now let's move on to the next one, which is that you give an intravenous anti-epileptic drug or anti-seizure medication. Now, let me emphasize it that you don't give here to treat the patient, but to test the modulation of the EEG and the modulation of the clinical phenomena when you give the anti-seizure medication. Because if you give the anti-seizure medication while the EEG is recorded, and you can document both a clinical and an electrographic improvement, then you can diagnose non-convulsive status epilepticus. Now, here you can see, for example, the continuous occurrence of epileptiform discharges, but their frequency is not high enough to qualify for the first criteria. So then we gave intravenous anti-epileptic drugs, and then the spike and wave disappeared, and a more reasonable background activity came back. Now, what we often see in the intensive care unit is that the EEG improves, but we cannot really assess the clinical improvement. Well, in these cases, we say that there is a possible non-convulsive status epilepticus. And then there is another condition when we say that there is a possible non-convulsive status epilepticus, namely when the change in time are resembling evolution, but they are not good enough to call it an evolution. So, for example, in this infographic, you can see there is a rhythm which starts on 2 Hertz and then it becomes 2.5 Hertz. Now, if it would go to 3 Hertz, then I could say, well, this is an evolution. But it does not go to 3 Hertz, it comes back to 2 Hertz and then 2.5 Hertz. So instead of this gradual evolution into one direction, it's a ping pong, back and forth, 2, 2.5, 2, 2.5. Well, this is not good enough for calling it evolution, but it's still suspicious. So we call this a fluctuation. And then we say that this is a possible status epilepticus. Now, again, to demonstrate this, I compress the EEG very much. So between these 2 gray lines, you have 10 seconds. So here you can see 30 seconds of EEG. And then you can see this around 1 Hertz or even less than 1 Hertz frequency. And then all of a sudden, this switches to the higher frequency and back to the lower frequency. So can you see this ping pong? This is the fluctuation. And this is in a common average montage, but I can show you the same in a longitudinal bipolar montage. So this back and forth change in the frequency, not an evolution. You recall the examples I showed you before. There was a gradual change in the same direction, but this is a ping pong, back and forth. So this is the fluctuation. Okay, so this is what I've just explained. So in this case, you say again that this is a possible non-convulsive status epilepticus. Now, you still need to address the issue of how long these abnormalities, these EEG abnormalities, need to be there in order to say that they fulfill the Salzburg criteria. And then the response is 10 seconds. And then people are shocked. How come I can say that 10 seconds is sufficient to call it a status epilepticus? But that's not what I'm saying. Because you remember I emphasized that the very first step, the input to the whole flowchart, was clinical phenomena for at least 10 minutes. So the 10 minutes criterion comes in already here when we talk about a clinical suspicion of non-convulsive status epilepticus. Then you do the EEG, and the whole EEG is abnormal, but the climax, the peak of these abnormalities, where they are so severe that they fulfill the criteria, it's sufficient to have them for 10 continuous seconds. Now, there is one more important aspect that I need to emphasize here. And if there are pediatricians among the audience, you will then certainly appreciate this. So children with developmental epileptic encephalopathies, they have horrible EEG all the time, but you don't want to overtreat them. So for the sake of the children with epileptic encephalopathy, we introduce some safety additional criteria. So for those with epileptic encephalopathy, we say that we also need an increase in the prominence or frequency of these abnormal EEG features when compared to baseline. Well, fortunately, we have many EEGs on these children, so we follow them up. So it's not difficult comparing the EEG now when there is a suspicion of non-convulsive status epilepticus with a control EEG 1 month or 2 months ago. And you also get good information about a change in the clinical state from the parents or from the caregivers. Now, if for any reason that cannot be done, so you don't have previous EEGs, or you have a caregiver who is just a step in and they don't know the patient, then you can make this branch of the Salzburg criteria compulsory. So you must make compulsory to try intravenous anti-seizure medication and see whether that modulates the EEG and that modulates, improves the clinical picture. So again, these two additional items were added for these children with epileptic encephalopathy to avoid we overtreat them. So we validated the Salzburg criteria in a large multi-center study. So we looked first at the inter-rater agreement of the Salzburg criteria, and these were really high, almost perfect, both in the patient group and the validation group. It was beyond 0.8, which is almost perfect inter-rater agreement. Of course, you need to train in the criteria before you apply. And then the diagnostic accuracy was really high. The sensitivity was very close to 100%. Actually, we only missed one patient with non-convulsive status epilepticus by implementing the Salzburg criteria. Specificity was a little bit lower. It was close to 90%. So we had some false positives, especially those related to the fluctuation. Now, the Salzburg criteria have been implemented in the new ACNS, American Clinical Neurophysiology Society's guideline for the EEG in the critically ill patients. Now, let me show you in this infographic, in this slide, how the Salzburg criteria were translated, were incorporated into the ACNS criteria. So here you can see the modifications we did in red color. So the first one is related to this input condition, because often in the intensive care unit, you cannot use the Salzburg criteria's input step, clinical suspicion of non-convulsive status epilepticus, because the patient was lying on the bed in the intensive care unit for several days. You don't know whether any clinical phenomena started. So instead of this, we made compulsory to infer the duration from the EEG. So you need, without information on this clinical suspicion, so you need the EEG pattern to be there continuously for 10 minutes. Or if this comes fragmented, so it's not continuous 10 minutes, but if it comes fragmented, then it should be equivalent to 20% of a 1 hour recording. So if it's fragmented, but then you add up the fragments, and in 1 hour, you should gather at least 12 minutes. That is the criteria. So this is what the modification related to the input, and this is an adaptation to the special condition where the patients are in the intensive care unit. Now, here you can see that the first two criteria are now called electrographic seizure. So here you don't have clinical manifestation or anything that could suggest there is a clinical correlate. So you have the continuous high frequency that is more than 2.5 Hertz spike waves. That is our first criterion, primary criterion. Or if you have this typical evolution in time and space, which I have emphasized previously in several slides. So the gradual change into the same direction, the gradual change of morphology, amplitude, frequency, that's the evolution in time, and the propagation, which is the evolution in space. So if you see these, then you call them electrographic seizures or electrographic status epilepticus. Now, if there are subtle phenomena, and then you, by doing EEG, you confirm that these have an epileptic origin. Then you confirm that there is actually a clinical manifestation. So that's why we call this now an electroclinical seizure. So you have both the electro and the clinical component, both the semiology and the EEG. Why? Because the EEG confirmed that this subtle semiology is actually a clinical correlate. So this is now electroclinical seizure. And also, if you see a clinical improvement also on intravenous anti-seizure medication, then it's called an electroclinical seizure or status epilepticus. And then the fluctuation now is an ictal inter-ictal continuum. I will talk about that later. So this is perhaps the new term equivalent to a possible non-convulsive status epilepticus. So instead of calling it a possible non-convulsive status epilepticus, you call it now an item on the ictal inter-ictal continuum. And then, of course, you try also intravenous anti-seizure medication therapy for them. Okay, now seizures or status epilepticus in critically ill patients are categorized according to the new ACNS criteria as follows. So as I showed you in the previous slide with the Salzburg criteria, we have the electrographic ones, where you have the epileptiform discharges with a frequency higher than 2.5 Hertz or a pattern with evolution in time and space. And then we have the other group in the ACNS, also derived from the Salzburg criteria. These are the electroclinical seizures or status epilepticus, where there is a clinical correlate time lock to the EEG abnormalities. This can be subtle phenomena too. And the clinical and EEG improvement with intravenous anti-seizure medication. And if it's only EEG, then it's just possible. Now the duration makes the distinction then between the seizure and the status epilepticus. So if it's at least 10 seconds, then you can call it a seizure. But to call it a status epilepticus, you need at least 10 minutes in one block. Or if it's fragmented, then summing up the fragments, then you should get at least 12 minutes. So this was the theoretical introduction which I wanted to give you, and before showing you some examples and before I ask you some questions, I just wanted to show you where I'm sitting right now. So this is the Aarhus University Hospital. It's one of the largest hospitals in Scandinavia. It's almost like a city in the city, and this is here. I hope you see my cursor. So this is here where I'm sitting and giving the lecture right now. But after giving you this theoretical introduction, now let me share my screen, my other slide, and then let me ask you some questions on cases. So just give me a second.
So the participants can reply on the chat box.
That would be quite difficult summing up now, and I don't think we set up, we did not set up a voting system. So I will just ask the questions, and then I will ask the participants to remember their answer. I will wait a couple of seconds, and then I will give the correct answer.
Okay.
So this is an internal game. Okay, so let's start with the first case. This is a 72-year-old male. He had a thalamic hemorrhage and right hemiparesis. And 3 days after the admission, the personnel observed altered consciousness. GCS was 10. They did a CT and there was no new lesion. Then they ordered an EEG, and then on the EEG, you see this. And I'm showing this to you in a common average montage. And remember that left in my system is red and blue in my system is right. And then you can see something here. Yes. So look at these things. And then I'm paging, so you can see the next screen. And the next screen. And the next screen. So would this fulfill the criteria for status epilepticus? So think about what you've seen. And actually what you've seen is a fluctuation. So let me go back to the slide so you can see this back and forth between the lower and the higher frequency. It's no evolution, it's just this ping pong back and forth. So this is a fluctuation, which in the according to Salzburg criteria would qualify as a possible non-convulsive status epilepticus. Now we say according to the ACNS that it's on the ictal interictal continuum. Now let me show you the next case. This is a 78-year-old female. 2 years prior to admission, the patient had an ischemic stroke in the right middle cerebral artery territory. Of course, she has a palsy on the left side. 1 day prior to the admission, she became agitated. They observed impaired consciousness, loss of consciousness, and periods of 30 to 90 seconds with discrete jerks in the left upper arm. The CT did not show any new lesion. And then this is the EEG that you see. And then it's in a common average montage. And then the green channels on the bottom, these are EMG channels. Now, you see some delta activity here in C4. But honestly, this delta activity in itself, without clinical correlation, would be nothing. It would not be an ictal pattern. Yet, you can see that it's time-locked jerk to this delta activity. And if you don't have EMG, actually, you could see the EMG artifact on the SCOP EEG channel. So here on the left side, what you see here, that's an artifact, that's a muscle artifact. But if you have muscle electrodes, it's very easy to put them on. Surface EMG is very easy to be recorded. So then you can see the time-locked jerks. Now, let me show you the video too. So look, when there is this delta, then is a jerk. Look at the arm. Yeah. Yes. So where does this place us on the Salzburg chart? Well, this is a subtle clinical ictal phenomenon during this EEG abnormality. In this case, this was the delta wave in C4, and then the jerk in the corresponding jerk in the left arm. Now, according to the ACNS, now this would qualify as an electroclinical seizure or status epilepticus if it's going on for a long time. Okay, let's take the next case. This is a 67-year-old male after cardiac arrest, a post-anoxic patient, and 3 days after the return of spontaneous circulation, they recorded this EEG. So look at the EEG. And then I can show you what's happening when we apply nociceptive stimulation, so pain stimulation. Well, what you can see is actually the EEG is continuous, which is good in a post-anoxic case, but there is nothing that would fulfill any diagnostic criterion for non-convulsive status epilepticus. Here, even if you focus here, there is a change in the frequency. You have more higher frequencies, so there is a certain degree of reactivity too in this EEG. But again, this patient does not fulfill the criteria of seizures or status epilepticus. Okay, let's see the fourth case. So this is a 71-year-old male, also after cardiac arrest, 3 days after the return of spontaneous circulation. Glasgow Coma scale was 8, and the personnel observed periods with discrete jerks. And then this is the EEG that we've recorded. So you can see the spiky GPDs with a high frequency. So this already fulfills our first criterion. There's no background activity, so this comes on a flat background and a suppressed background activity. So this fulfills again the criteria, actually the first criterion. So this is a seizure or status epilepticus if the duration is longer. Then the other question is the prognosis. Well, in this type of etiology, this is not a good prognosis. But where does it situate us on the Salzburg chart? Well, it's here. This is the first criterion. So you have the continuous epileptiform discharges because with a frequency beyond 2.5 Hertz. So I hope that these cases helped you to understand how the Salzburg criteria and these EEG patterns, which are now included in the ACNS guidelines, are applied into the clinical practice. So thank you for your attention, and I would be happy to take questions.
Thank you, Sandor. I think you've been very precise and you've shown excellent examples of all the scenarios which you taught us. I'll just check, Sir Mendiratha, sir. So I'm just checking for some questions.
Sure.
Everybody is just appreciating your talk and they've understood everything. So as of now, there are absolutely no questions for the first time in the EEG workshop. So, so as I said,
that can be very good or very bad.
I think it was very good.
Everyone, or things are clear.
It was really very good because your case examples were very precise and you know, they really helped us. So I had a question. One is that, you know, when you're suspecting non-convulsive status and it fulfills the criteria and you give you know, a graded midazolam dose intravenously. However, the patient, so you think in your mind it's non-convulsive status and you're giving intravenous midazolam because it fulfills the criteria, but the patient really doesn't turn around or, you know, improve. Right. Then what is the next thing to do? Because that does happen, you know, it's not uncommon for that to happen.
Right. And a very good question, and that's our real clinical scenario, and that's when we really need to make decisions also on the long term. But this is beyond the diagnosis. So you already diagnosed the non-convulsive status epilepticus. So this question brings us into the domain of the prognosis, and then the tricky thing is that then you must start discussing the etiology, because it's the etiology that really helps you in telling you what the prognosis is and whether, well, it's just a waste of resources doing more therapeutical attempts or there is a good chance. And I think the best way to address this is the classical chart by Bauer and Trinka. So they have this vertical axis and the horizontal axis, and then they say that what's important is the mixture between the structural and the functional abnormality. And then you have the one corner, the one extreme of the spectrum, where there is a huge functional component in it, like in a patient with, I don't know, a patient with idiopathic generalized epilepsy, a teenager with juvenile myoclonic epilepsy who did not take the medication because he wanted to go to the discotheque and have some wine or whatever, and then he comes to the ER in status epilepticus. Well, there you don't have a significant structural component. There you really treat because you know that you have good chances this kid will be on his feet again. But then you have the other extreme of the spectrum. For example, you have a huge brain tumor, or you have a post-anoxic case, flat baseline. There, you know, you have a huge structural component in it. And then it could be that you treat the EEG of corresponding to an epileptic pattern, but then you have the huge burden of brain cells which died, or huge structural damage which you can't really do anything about. So in that case, there's no much use in a very aggressive treatment. So I still think that in spite of much advance in this field, it's still the chart by Bauer and Trinka which gives you the answer to this question.
Thank you. So there are some questions. Dr. Ekta has asked, of course, you did mention it in your talk. Can the same criteria be applied for pediatric cases as well? So this is her question.
Yes, so yes, and we, as I emphasized, we have some specific criteria to the epileptic encephalopathy, so that would apply especially for the pediatric population. And in our validation study, which we published together with our colleagues and friends from Salzburg, we also included children. So yes, it does.
There are some more questions. So can we continue to take them?
Yeah, please. Sure.
So there's a question by Dr. Triveni. Can you explain spatiotemporal evolution?
Yes. So this is, like the fingerprint of the ictal EEG pattern. So I always teach my student that guys, an ictal pattern is not a dead pattern. It's not a monomorphic. It's not like a machine going on, but it has its own life. It changes in time. It changes in space. Like living objects, they move, they develop, they change. So that's how an ictal pattern behaves. And this is very important because that's how you distinguish the ictal pattern from an interictal pattern, which do not have this evolution. So this gradual change in time and gradual change in space, this is the fingerprint of the seizure activity. And why this is, it's based on the network dynamics. So as a seizure and the ictogenesis is within a network, and this network dynamics gives you this gradual change in time and space, which then you use as a kind of biomarker for calling it a seizure.
So another question by Dr. Jitin. Can you shed light on EEG patterns of non-convulsive status in post-craniotomy and craniectomy patients? So would they be a little more higher amplitude or frequencies would be high? I mean, he just wants to know the pattern.
Yeah, so basically you need some adaptations here, because although the same principles apply, you would have some special circumstances, like there would be perhaps there are some areas on the scalp which you cannot cover because you don't have place where to put your electrode, or you have a breach rhythm or a breach phenomenon which gives you a much higher amplitude, and then you have lots of rhythm. But again, there the same principles apply because you look at the evolution of the rhythm. But again, if you are not well trained and then you say, "Oh, this is spiky and it's big," then that's not enough to call it a seizure. You need to see also this evolution in time and space. So basically the same principle apply, just take into account that your spatial sampling is different, and then take into account also this breach effect.
The question by Mayuri. Does PEDS, which is periodic, discharges, come in NCSC? So basically, I think you should be talking about the interictal-ictal continuum. She's got a query there on that.
Right, and the short answer is yes. So if their frequency, so you can have periodic discharges at so high frequency that they immediately fulfill the criteria. And I showed you several examples. For example, on I think the last case was a GPD with a 3 Hertz frequency. Well, it immediately fulfills the criteria. Then if you are in the lower spectrum, lower frequency spectrum, then so under the 2.5 Hertz, then they don't fulfill the criteria. Then you are in, as you said, Manjari, then it puts you into the ictal interictal continuum, and then you need to do some additional things to confirm that indeed it's a seizure or not a seizure, like trying an while you do the EEG recording, trying an intravenous anti-seizure medication.
There are some more questions. There's an interesting question here that NCSC in epileptic encephalopathy, clinical or electroclinical or both parameters, which of these carry more importance in regard to response to AEDs? This is asked by Dr. Balaji. So he says that when you have, non-convulsive, whether it's electroclinical or it's clinical, how would you rate, in your experience, the response to the anti-seizure medicines which you are giving for both these different...
In children with epileptic encephalopathy?
No, he doesn't mention children. He's just saying general.
So whether I put more emphasis on the clinical or on the EEG?
Yeah.
Well, unfortunately, I need to, the clinical improvement, that's, I must say upfront, that's a rare, very happy, but rare occasion. So you really feel like a doctor, you help the patient. But that's, mainly a case in the ER where you get a patient with known epilepsy who forgot to take the medication or went into a status epilepticus for any reason. Then you can have this very positive outcome where you see the clinical improvement also. You rarely see that in the intensive care unit. Now there are some tricks which can help you to increase increase your chances to get the clinical improvement too. For example, opting for a non-sedating anti-seizure medication, so going for a non-benzodiazepine instead of a benzodiazepine, because after benzo the patient would sleep. So then you just shut down the possibility, or in most cases you shut down the possibility to evaluate the clinical. So although I would love to have the clinical improvement, I mean, I rarely get it. So most often I should rely on the improvement of the EEG.
Sandor, I think this will reflect when person is in altered state of sensorium, like whether it is comatose or it is stuporous or drowsiness. But with the anti-seizure medicine, which doesn't cause sedative or hypnotic effect, the patient starts waking up. That will be a good indication. Yes, this was status epilepticus, probably non-convulsive, and responding well to the treatment. I think that's what we experience in our intensive care unit. Yeah.
Yeah,
Okay.
absolutely. So that's, that's the best case scenario, but unfortunately you don't see that too often. But yeah, if you see that, then you're happy. I mean, that makes your day.
So this question is interesting. Is there any criteria for the improvement in the background rhythm when the patient responds to IV midazolam? I mean, do we have, one is the spikes and all will disappear, but do we have any quantified or any stated studies which have said this kind of shift should be there or change should be there? That is if delta improves to theta or whatever.
Right. This is a very, very, very good question, because when we developed these criteria, we did not spell this out. So I fully agree. This is a very good question, because we didn't explain, or we didn't specify this sufficiently. Now I can tell you that a working group has now developed consensus criteria. This is expert-based consensus criteria, which we will submit very, very soon. What I can tell you is that our experience is that the improvement of the background activity is rarely useful as a criterion in the intensive care unit. So we kept the improvement of the background activity, we kept that for the non-critically ill patients, because still you need criteria for status epilepticus outside the intensive care unit too. But in the intensive care unit, we don't need improvement of the background, but we need a significant improvement in the interictal-ictal continuum. So for example, if you have continuous pattern, for at least 10 minutes, then when you give the intravenous anti-seizure medication, then you should induce at least 1 minute of cessation of the spikes, or that pattern which qualified for the ictal-interictal continuum. Now, if you have these fragmented ones, where you have some breaks in between, but you sum them up, and then this is at least 12 minutes per hour. In those cases, we need at least 3 times longer break, so 3 times longer period without ictal-interictal continuum than it was spontaneous. But again, this is still a manuscript. I hope this will be published soon.
Sandor, one more question.
Yes.
When we are first is high index of suspicion, second is diagnosis, and then what is the therapeutic objective? Is it disappearance of electriform discharges? Second is suppression of electriform discharges, and the third is the clinical improvement. So what really we are looking for? Suppose the disappearance of electrical discharge, is that sufficient? Or still we should?
So your ultimate goal is the clinical improvement, but that's something which is far away in time, and then until you get that, if you get that, but until you get that, you need to focus on things, on outcome measures which you can see immediately or within 10-30 minutes, and that's the EEG. So a total cessation of the ictal pattern or the ictal-interictal continuum pattern, and then also as much as possible disappearance or as a significant drop in the epileptiform discharges. So that's what you can see on the short run. But of course, on the long run, it's the clinical improvement that you are after. But let me mention again that this depends very much on the etiology. So depending on the etiology, this is almost mission impossible. And then in other etiologies, this is something you must achieve. So you need to treat aggressively because you know that you have a good chance. And again, I refer back
No,
to
being a clinician and clinical epileptologist, what I normally see is that suppose are we happy if we have been successful to suppress the epileptiform discharges, so that there is no further ongoing damage. But suppose the epileptiform discharges have disappeared with whatever the treatment non-sedative you give, but patient doesn't wake up for many hours or a day, then what next to do?
Yeah, again, this is then the difficult case of treating refractory status epilepticus, and that's indeed a difficult question, but that's beyond the topic of today. But of course, then if you have tried the second line, then you go on to the third line, and then each center has its own algorithm of treating the refractory status epilepticus. But that brings us to the difficult question of how to treat the refractory status epilepticus, and it's no really strong evidence to answer that question.
No, what I am saying is, suppose epileptiform discharges have disappeared. There is a continuous EEG monitoring. Those have disappeared. It is a non-convulsive status, not convulsive status. So in that, what next to do? 6 hours have passed, 10 hours have passed, patient condition has not improved. Then what next to do?
Yeah. But again, this depends on the condition. So if you see this in a post-anoxic patient, then yeah, you know that you treated you gave lots of medication to suppress this epileptiform pattern. The patient is not doing better because the prognosis is rather poor because of the etiology. Now, in cases with a good prognosis, usually I can see that the clinical improvement, although it can lag behind, so it can come later than the EEG improvement, but if the etiology makes it possible, then the clinical improvement will follow. But whether the clinical improvement will follow or not, that depends very much on the etiology.
No, say it is metabolic encephalopathy, common metabolic conditions we see. We try to take care of metabolic component as well as take care of the non-convulsive status epilepticus. Suppose my hyponatremia, hypoglycemia, I have taken care, or in kids hypocalcemia, I have taken care, and EEG discharges have also suppressed, but still patient is not coming out because here is direct interaction with the family member. They ask, doctor, what has happened now? So now what next? So suppose 8 hours, 12 hours have passed, but please guide us, what should we do next?
Right. So again, a very, very important aspect which you yourself emphasized it, that you treated the condition, you treated the etiology. So, but again, if the etiology is treatable, and if the EEG is improved, then the clinical improvement in most of the cases would also come. So again, if the condition is treatable, if you treated the condition, and then if you can see that the EEG improves, then that's a good thing, because then you can tell the family that yes, the clinical improvement can lag behind, but it's highly likely that it would come.
Why I was saying this, which I have experienced, it's like a therapeutic window. Like we say for thrombolytic 4.5 hours. In these also, earlier we intervene when there's a reversible stage, rewarding are the results. If it's a non-convulsive going on for some time, but we have diagnosed after 12 hours. In that situation, there may be apoptosis, some degeneration happening, and recovery may not be parallel to the recovery in electrical discharges.
All right, that's also correct. So the time window is very, very important, and time is brain. So the earlier you treat, the better, the more you can save. But again, if the condition is reversible, it also in an intoxication, for example. And if you treated the etiology and if you suppress the EEG, then you have a higher odds that the patient will recover, although the clinical improvement, as I said before, can lag behind the EEG improvement, but it would come. But it's very true what you mentioned, that the earlier the better.
So we've approached 8 p.m. There are some other questions here, but I think we can, take off for the day. And, you have your second class, so we will deal with some of these questions there because they would be answered there too. So thank you, Sandor, for
Thank
this
you. Thank you
lovely
so much. And
talk.
looking forward to seeing you again.
Yeah, and we all, on the behalf of the Indian Epilepsy Society, really have gratitude because you've taken out so much of time to explain everything. And
Thank
I'd like the president to give his final remarks. Yeah.
So it was a wonderful teaching session. As I said, I call Sandor, for Sandor, I have a word. He's an open access teacher. He's an open access teacher. Always
That
through
is
the
right.
global platform, he
Yeah.
keeps on doing. And it was indeed wonderful. And we all enjoyed. And main happiness comes from when participants say, very good session. So that is very heartening. And we'll keep on troubling you, Sandor, again. And
My pleasure.
thank you so much. All the very best.
Thank you. Thank you so much.
And
Thank you.
now I can say now you are approaching good evening. I think from good transition from good afternoon to good evening. Yeah, close to that.
Thank you. Thank you so much.
Thank you
And
so
see
much.
you soon then. Thank you.
Good night.
Goodbye. Goodbye.
Thank
Thank
you.
you.
Bye bye.